Donovan, thank you. It's a pleasure already speaking with you, and I thank you for your time.
No, Renee, it's my pleasure. Certainly happy to have you here.
Well, I want people to get to know you, and then I want to talk about Pikeville Medical Center, because you have an interesting background to get to where you are, and that'll help people connect the dots of why Pikeville Medical Center is doing such innovative work. Tell us about your previous life.
Well, I started my first real career was with actually Lowe's Home Center. So I was with Lowe's for about 17 years. I was a store manager and then a district manager. Lived actually over central Kentucky, so I managed Lexington, Louisville, Corbin, Somerset, so pretty diverse. And I lived almost every community throughout Kentucky as well in doing that. And then I retired and went to work for Ferrellgas. I was a regional vice president, operations VP for them, managed 4 states. And I was living in Pikeville. I was able to move back home. And then one of the guys that was working with me, I should say, and for me at Lowe's and then Ferrellgas, happens to be the mayor of Pikeville right now, Jimmy Carter. So Jimmy had just came on the city council and said, you know, I think you would be a great fit for a position that's coming over as city manager. You might want to consider. So after a little thought, I interviewed and was given the opportunity. So I spent 13 years in government. Loved what I did. I had plenty of opportunity to leave Eastern Kentucky, but once coming back, my intent was to stay here. I wasn't going to leave again. Ironically, I told the mayor, which was at that time, it was Frank Justice, a dear friend of mine, that the only place I would ever have interest in leaving the city for would be Pikeville Medical Center. And I didn't tell anybody at Pikeville Medical Center at the time, and my wife was actually serving on the board of directors. And the previous CEO and President Walter May reached out and said, come over. We're looking for transition. I'm going to have to retire, and we'd like to offer you a position as the assistant CEO with the opportunity to transition in to this position. And so now, 6 years later, with a very diverse background in more business, finance, learning healthcare during a pandemic and financial struggles and all the things that healthcare has had to endure over the past few years. So here I am.
Well, that is an interesting trajectory, to say the least. And I think about your city management experience. How did you parlay that, particularly during the rough times during COVID when there was so much uncertainty and transition for lots of industries, and healthcare, of course, taking the biggest brunt of the change and transition?
Well, you know, it's interesting because one of the things in working with city government that I had the opportunity to do was establish a lot of great relationships. So, you know, having relationships, you know, not a D or an R, but in the middle, my job, you know, as city manager is to really work in the middle and to work for the better good of the community. So having those connections, and when I came to work in healthcare and COVID hit, you know, knowing what branches to reach out to, knowing how, in essence, the flow of politics kind of worked, that was my strength. On top of having a very diverse financial background, because what hospitals faced all of a sudden was the financial downturn. It wasn't just a workforce issue that hit us. Because of COVID, people had to mask, you know, kids going to school to come into nursing was second thinking that. And then, you know, all of a sudden we made changes throughout the nation and the state both. We cut out our elective procedures that impacted us financially in a very harsh way. But one of the things I was very proud of at the time, and still am, is that after going to I remember like yesterday and bringing the chairman of the board at the time in and saying, look, you know, I'm projecting probably a $10 million loss in 1 month. And I mean, it's you know, it takes a lot of fuel to run a huge hospital such as this. But we were able not only to do it, and obviously we had a lot of help from the state and federal government with subsidies and such. We still had a tremendous loss, as did every other hospital and state throughout the region and the nation. But what I'm very proud of is that we did not lay off. And I'll say this: we did let 100 people take voluntary layoff during that time, but it was a time to where there was subsidized through the federal government, where they could actually go home and make more money than they were working. But every single employee we were able to bring back within a very short period of time. We didn't cut any services. As a matter of fact, during COVID, we actually expanded services. We opened our first children's hospital in the eastern part of the state. So maneuvering through both using my financial background and then also my knowledge of government. And then the other piece of this is any great leader, it's not about being a great leader, it's having great leadership with you. Is that I have a very diverse team that is absolutely, you know, my 8 executives understand this business, so where my weakness were, their strengths were. So we were able to pick each other up, and that's the great thing, Renee, about being part of a hospital like Pikeville Medical Center, is that we're an independent nonprofit hospital, so I can make a decision without having to go through a lot of tape. I am the decision maker in essence, and taking certain things to my board of directors. So we were able to pivot on a dime. And then the beauty of, because of who we were, during the pandemic, and especially during the time that we were administering the vaccine. We were chosen as one of the 10 hospitals in the state that got the vaccine first. It really set the way because of our regional outreach. So we played a huge role, being the first and really only Kentucky hospital at the time, to get into different aspects of how we were dealing with COVID. So it was interesting, but we made it through it, and it made us better. We made a lot of relationships along the way, and certainly our people benefited from it.
$10 million a month.
Yes.
That you lost. Have you recovered from that?
It's been slow, and one of the things that I commend this administration on, and it is administration, it's because it's administrative function, and certainly the legislators also, because during the last session they passed for HRIP, which is the advanced Medicare payment. Without that, hospitals throughout Kentucky, no doubt in my mind, I sit on the executive committee for KHA, Kentucky Hospital Association, on the board of directors. So I get the opportunity to speak to almost every large hospital state on a monthly basis. And I knew their financial position was no different than ours. So the way we rebounded, in essence, was COVID taught us to be a little sharper with our pencil. So we were able to really make changes that really needed to be made as an organization. And then on top of that, with the subsidies, and then HRIP came into play. So the inpatient HRIP hit first. We're a little bit unique and different. When you look at Eastern Kentucky specifically, unfortunately, we lead the nation in pulmonary, heart, cancer, about every disease you can think of, and we have the poorest counties in the nation. So my payer mix is 77% government paid. So, the federal government, state government dictates in essence 77% of my income. Right. So when the HRIP piece went into play, it allowed enough revenue to sustain us. Now with the outpatient piece, we're finally able to start catching up, because we've had, we have named our healthcare workers, and they've been phenomenal healthcare heroes. But the problem is that they have also sacrificed, because a lot of them did not get pay raises along the time. So we're catching up on a little of those things, as well as making additional investments in infrastructure, leveraged with a lot of grants and federal assistance as well. So we're now at the point to where we're back out of the red. Not a great deal. We are stable, but there's certainly a lot of work that needs to be done to make certain that hospitals, especially, and again, without HRIP, and I know other states throughout the nation is looking at what Kentucky did to see how that they can kind of emulate that. And what the beauty of what was done is that they tied CMS, and working with the cabinet, tied quality to this advanced payment. So what you're seeing throughout the state of Kentucky is a level of the quality of care continues to go up too. So it's not really about just money. It's about being better and offering better and more services to those that we serve.
Yeah. We've heard Kentucky Hospital Association a lot during this most recent legislative session. Nancy has testified, and her surrogates have, and we continue to hear even during the interim about the nursing shortage and other provider shortages. So when you think about the specific needs of Eastern Kentucky, which, as you just laid out for us, are different and more exacerbated when it comes to disease management.
Absolutely.
What position are rural hospitals in? I mean, we've heard rural hospitals closing.
Yep.
It doesn't seem like you're in danger of doing that, but if you look at the landscape, how fragile is the ecosystem?
It's very fragile, and the concern is that if HRIP was diminished or goes away, hospitals will close. Absolutely, no doubt. So if you look at Tennessee as a good example, 40% of Tennessee's hospitals right now, especially in the rural communities, are at risk. When you look before HRIP, Kentucky had, I think, somewhere around near 20. It was around 18, 17 hospitals that are at risk, and that's down to 4 now. So HRIP has had a tremendous impact, but it's also, again, and it really isn't just about the financial piece, because quality, readmission rates, keeping people out of the hospital, keeping them healthy is a huge piece of this, and it's an investment, again, the sickest people in the nation right now who really need help the most. So, KHA can't say enough good. They've really been great at lobbying and really telling the message, because there is concern. There is concern, especially in rural health. If you look at Eastern Kentucky, we represent half of the city of Pikeville, one of the most progressive cities, occupational tax. So without us, they lose a substantial amount of pay. So it's about also economic stability. When the coal industry was impacted, healthcare rose and represents about 17.4% of the overall economy in Eastern Kentucky. So when you look at not just the economy, you look at the number of jobs that's created. I have 3,100 employees. ARH, who's they're our friends and our competition. They have about 7,000.
Appalachian Regional.
Appalachian. Holly Phillips is a dear friend of mine. So we are the healthcare systems.
Right.
I'm a different type of hospital than what Holly is. I have a higher level of care. We take the transfer patients from ARH. They administer great care in the communities that they're in. But the concern is, again, is that it is extremely fragile. When you look at specifically Eastern Kentucky, and I use who we are, we offer almost every service that a UK or a U of L offers. There's 3 medical schools in the state of Kentucky. UPike has one of them. We have a relationship with that medical school, along with the optometry school, and soon to hopefully be dental school. So when you look at what we're offering a lot of those same services, but things like our specialty services such as endocrinology or rheumatology, those services did not exist 10, 15, 20 years ago. I have RA. I travel to Lexington all the time. Now I've got great RA physicians here. So the reason that's important is that the financial stability of rural hospitals without protection is that those are services that aren't profit makers for us. We provide those services because it's the right thing to do. If we don't have financial stability, then those are the services we end up cutting first. So those are, again, our citizens within Eastern Kentucky that are then denied access to care that end up back in Central Kentucky, which is already overburdened. You saw UK's just announced a $2 billion expansion project in trying to create more beds because those higher level of care that's needed, they're running out of beds also, are transferred to them, or they're transferred to hospitals like ours. So it is very, very fragile right now in where I think, not just think, the numbers prove that we would go without this financial stability. So HRIP has played a huge role in who we are and what we're becoming.
The recruitment of talent, of specialists, is that more of a challenge for you because of the region?
It absolutely is. For 2 reasons. One, because of the region we're in. It's hard to convince somebody that's graduating out of New York or Chicago to come to rural Eastern Kentucky. But there's also, when you look at, and you mentioned earlier, there is a crisis right now in the U.S., hands down a crisis. Now we created a new product, and I call it a product because that's what it is and that's what I do. So 4 years ago, I created a program called Project HEART, which is an acronym for Healthcare Education Around Regional Training. So when you look at me, I have 1,000 nurses, and I'll come back to your point on doctors because they kind of correlate. So when you look at nurses, I have 1,000. Right now, Becker's reports that by 2025, the nation will have 450,000 nurse shortfall. In Kentucky, a recent study that was done through KHA shows that we currently have 3,000. And if you look and project to 2035, if nothing happens, we only gain 100 nurses. So this is a huge issue, and it impacts our finances also because of the traveler. When you look back at April of last year is a good example at the number of travelers I had to have in my organization. Those travelers cost me $3.8 million a month, more. And every hospital was going through this. So now that, again, the travelers are going down because the demand of COVID has kind of impacted us, but we still have nearly 100 travelers in our organization. So
is that traveling nurses?
Yes.
Just traveling nurses. When you say travelers, just so people...
Yeah, I'm sorry, it's our own internal terms.
Sure.
So we know what we're talking about, and I apologize. But we also have travelers in other positions as well.
Really?
So lab techs, respiratory, because there is a huge national shortage. And when you live in Eastern Kentucky, and there lies the problem. So I've had multiple meetings in Frankfort and what Project HEART did. So if you look back 3 years ago, I have 1,000 nurses. The national attrition rate in healthcare was about 17% at the time. So at any given time, I need about 150 to 170 nurses. In Pikeville, we had 2 nursing schools, the University of Pikeville and ANU. Between the both of them, they were producing 80, and if you look at the success rate of the boards, you're only producing actually 60. So I need 150, and then all of a sudden, that's before COVID.
Right.
So now the crisis hits. So realizing that was coming, worked with my federal and state partners and said, we've got to do something. I want to launch something different. So we created a program under Project HEART. We have multiple leaders, and I'll leave somebody out if I start mentioning them. But the bulk of them are in higher ed. So we went from, I partnered with UK, I partnered with Galen College of Nursing, I partnered with KCTCS with the Big Sandy campus, I partnered with National University. So National University and Galen are actually in buildings on my campus now. We actually built them nursing schools. So we worked with Big Sandy, ANU, and a couple of others to where we now have, for the first time, a allied health program in Eastern Kentucky. So we have lab techs, we have respiratory, we have rad techs, all these positions. So and then we've created scholarship opportunities where the hospital is actually paying students while they're in high school.
Wow.
So we have a workforce innovation center that we just launched. We have all these high school students that come to us. We actually get as far down as to kindergarten where we do these sessions. And as a result, we pay them to go to school with a commitment that as they graduate, that they will come to work for us. And if we choose not to hire them, then they can go to work for my competition, but they still get the economic benefit. So through all that work and through these partners, I just said we had 80 healthcare seats. Now we have 540. So we're now, and one of the things that really aggravated me even coming into this position is that there was a story done on a national network that interviewed a few high school students that was getting ready to graduate. And they were in a gymnasium, and they were interviewing them, and they asked them, what are you going to do? And the answer was the same, is that we're drug infected and there's no job opportunities. Look, I grew up in Chicago. I'm from this area. My dad was from this area. I know what drug, and not saying there's not a pandemic. It's in a lot of communities. But unfortunately, Kentucky's got labeled as such. Right. And then if you look at the number of job openings, I'm sitting here in any given year, I've got 300 or 400 job openings and begging people to come to work. So COVID aspirated that to a point to where we've got to be able to present opportunity, because statistics will show that if you have a student that's from the area, they're committed to the area, they go to school in the area, they'll stay in the area. So you get continuity of care also. So we see it as an opportunity that is an investment. As HRIP moves forward, the intent is that we will start, and UPike's a great example. UPike, when I first started 5 years ago, had 30 nursing seats, I'm sorry. Now they have 140. So we are now moving students through the system that in the next year we will start graduating that first batch. So we'll have close to 300 nursing seats in our community that will be graduating, that we'll be able to offer these opportunities to. And it's not just for us, it's for ARH and other providers as well, to kind of fill the gap and to kind of, again, lower that overall cost of for the traveler, nursing RN travelers. But more important, you're putting people to work in Eastern Kentucky. You're creating jobs. You're creating secondary families that goes to work for the other service areas in the area. So all that's great. Well, the same problem we have when you look at the national statistics with physicians. So there's a huge shortage of physicians nationally. And when you look at Eastern Kentucky specifically, is that we are underserved traditionally in certain fields. So trying to recruit somebody away from a UK or U of L, and they're good friends, is difficult because of the amenities that are offered.
Right.
But the beauty is that I was just telling this story a little while ago, is that the easiest recruitment tool that we have is that our hospital has really advanced technology. So our heart and vascular program really is almost second to none in the state. And we traditionally rank third or fourth for the number of open hearts that we do. So when we have a physician that comes as a cardiologist, they walk our facility, they cannot believe, I have more cath labs than any other hospital in the state of Kentucky.
Wow.
We just opened a $35 million expansion of our heart vascular center. So cancer, heart, orthopedics, et cetera. We have some most advanced and technology that's offered. So once a doctor walks, they are absolutely blown away. And my sell is that Eastern Kentucky, and I make this joke, Renee, and I'm sure you'll get a smile. My wife tells me I'm not funny, but I think I am. But rush hour. I live down by Walmart up on the hill, so it's about a 10-minute drive. And I said, the difference here, growing up in Chicago, is rush hour for me is the difference between 10 minutes or 12 minutes. So you don't have to worry about all the hustle and bustle. But also, if you look at where Pikeville's located, and you draw a ring, you can be in Johnson City, Kingsport, Ashland, Lexington, Winchester, about any major market within an hour and a half to 2 hours. So you're right by airports and infrastructure and all those things that you want to be by. But you still get that hometown feel to where when you walk into Texas Roadhouse, everybody's going to know you.
Right.
And that's phenomenal.
And that's the selling point. That's the closer. It
absolutely, and that's why I'm here. This is home, and this will always be home, and it's because of the people of Eastern Kentucky and what I have had the privilege and honor to do, not just with the city, but now taking care of our many patients.
So let's do by the numbers, because let's get the stats on how vast this medical complex is. Tell us about that.
Pikeville Medical Center is a huge organization. We have about 2 million square feet of space. We're the only level 2 trauma center in in Kentucky. There's 2 level 1s. The difference between a level 1 and a level 2 is just we're not an educational facility. So if we were like a UK, we would be a level 1. We have 9 centers of excellence. So when you talk about orthopedics and cancer and heart vascular, all those are separately branded. I mentioned earlier we have over 45 facilities. Really, if you want to count the outbuildings, it's 52, I think, is what we're up to. When you look at our staff, we have 3,100 employees that's represented in 4 different counties, 3 in Kentucky. We serve up 450,000 people in a diameter of their, again, basic needs and more advanced needs. We have a full clinic. We have an 11-story clinic that has about every specialty and subspecialty that you can think of. It sounds like I pick on UK and U of L. Again, these are good friends of mine that we serve on the same board together. But pretty much we offer almost every service that a UK or U of L offers outside of we don't have a burn unit and we don't do transplant. But outside of that, there are more advanced cases that a university has to do. But for the most part, we have the technology, the ability to be able to do that. So we do about 503, I'll round it up, 1,000 encounters a year as an organization. So if you rank us by size in the state, we rank around the 10th from the standpoint of size hospitals out of 120. So, and there's a lot of, obviously a lot of system hospitals that do a phenomenal job. So we're the largest employer, single employer in Eastern Kentucky. We represent, as I mentioned, a significant amount of the tax base. So it really is about access to care. I mentioned earlier we have the first children's hospital that we opened up in Eastern Kentucky, the Metu Children's Hospital, named after a dear friend who's a board member who's been in pediatrics, Jody Metu. And then on top of that, we've made a significant investment in pediatric care as well, and that's been my passion. We opened up the AVA Center, which is the first ABA center in Eastern Kentucky, and it has near and dear to me because my granddaughter's on the spectrum, and it was named after her, Ava, which she's absolutely phenomenal. She's in just graduated kindergarten, top part of her class. She's absolutely brilliant, and she's Pop's baby girl is what I call her. But we have 8 graduates today. I've got in that center, just to talk about the needs in Eastern Kentucky. Currently, we have 570 kids on our waiting list. There's a huge national shortage for BCBAs or the clinical component, but that's the problem throughout the entire state of Kentucky. So I'm working with higher ed to see if we can open up more BCBA opportunities.
And what is BCBA?
It's a behavior analyst is what, in essence, what they do is they're the ones that actually put together the health plan for ABA therapy for a child on the spectrum. We accept kids in our program between the ages of 2 and 10, and then you opt out at 12. But and most of our, we call them learners, most of our learners in the program are between 2 and 6 per average. But it's unique because when the neurons are firing at that age, you can really help them become the best that they can possibly be and give them the greatest opportunities. So we have kids that are nonverbal that use AudioVox, so we teach them to talk using a mechanical voice. So you can imagine wanting to drink water or having to go to the bathroom and not being able to say. So, and I say this frequently, is that healthcare is not a disability; it's a different ability, and you have to learn to be able to bring that ability out. And to see so many accomplishments, hearing a 5-year-old say "I love you" for the first time brings tears to your eyes, and living through it personally also has been rewarding in a sense because it also lets me understand the significance of that. But it's outside even the AVA Center, and we opened our first satellite in Prestonsburg last year also. So we're going to have by the end of this year about 130 learners in our program.
Wow.
Which is phenomenal. But we also have done things like we were the first pediatric ready hospital in the state of Kentucky with our ED with autism certified. We opened up an ED ward for pediatrics specifically. We launched our telehealth Healthy at School initiative that put telehealth in every single Pike County school system. We offered them to the adjacent counties as well. So now access to care, so a child that's in school, giving them access is extremely important. So when you look at Pike County, the largest geographic county, you look at where Phelps is, it's almost an hour away drive time. So now you give a child at Phelps the opportunity that when they have an earache or a cold, I can give them a physician or a nurse on telehealth that gets them care. So it allows the parent to continue working without having to miss work. And so it does a lot of other things to kind of bring the community and the region together as well. So Our NICU, we just graduated to a level 2 advanced NICU 2 years ago. The beauty of that is because of the type of specialists that we have here and the services that we have, we're able to take care of babies at a lower birth rate or that are premature, to where for years and years that child was flown away and separated from its mother or family, and that doesn't have to happen now. There are rare occasions where we have to do that because of a higher level of care. So I'm very proud, and that's what I was trying to say earlier, is when you look during COVID at a time to where hospitals have struggled, and we have struggled also, working with our federal partners, we have received a tremendous amount of various grants to be able to leverage our cash that we did have on hand to make investments that are giving a greater return. So the Ava Center, for example, also employs 70 new people in Pike County that never had a job before that are in this field. So it has had a great impact. But our biggest challenge still yet is, I just had a meeting this morning with my Chief Medical Officer, Dr. Crum, talking about the need and the recruitment of bringing more physicians, because there is such a need within the area, and we do struggle. Yeah. Typically, it's kind of unique, because what you heard me say is that rural hospitals oftentimes are in the poorest parts of the county or the state, and so they have a higher payer mix, so with government pay. So we don't get a lot of commercial insurance, but yet we pay our people more because of the demand. So to recruit somebody here may cost 10-20% more, and we have to justify that because there's guidelines and rules that we have to follow as well. So it's can you imagine during the time of COVID to where inflation hits you, the transport piece hits you, on top of that your workforce salary goes up 30%, and I'm not a retail guy anymore. I can't raise prices because the federal government still pays me what the federal government does. So that's why things like HRIP is so important. There's a huge issue coming up in the legislators, I'm sure this year, because it was last year, over CON.
Certificate
reform.
of need.
Yeah, certificate of need reform. There's a recent poll that done, KHA was involved in, that only 3% of those polled knew what a CON is, a certificate of need. So, it's extremely important to protect the integrity of the CON. And I met with 3 legislators this week, as a matter of fact, explaining that when we talk about free market, it's not really free market. Because again, imagine you're saying there's free market, but through EMTALA, I have to accept patients through my ED, whether they can pay or not. A private person doesn't have to do that. 77% of my payment is dictated to what you're going to pay me. But yet we've made investments, USDA, I tell people, I joke, USDA actually owns the hospital because of the debt service that we're carrying. But without the protection of CON, then there's many services. You may be able to bring in one competitor, but there's 15 services you're going to give up because the one service they're going to cherry pick from a standpoint and really pick you apart to where it impacts your profitability, which overall impacts your market. So if I end up having to lay off 100, 200, 300 people, then that impacts the Walmart, that impacts the restaurant across the street, et cetera. So it is a huge issue in trying to really help educate folks to what, and those that need to be in the know, the importance preservation and why CON is so important.
And it's interesting because I think that CON conversation started with Northern Kentucky because of St. Elizabeth and that area, Jay Williams, who represents that area. So we don't think about that really. I didn't think about it at the time, how it would affect rural Kentucky, particularly Eastern Kentucky. Absolutely.
It again, in my opinion, this is very strong language I used with legislators in saying it wipes us out. Because we're not underserved. We have all these services, and we have built this facility because we have the highest pulmonary disease, the highest cancer disease. Well, imagine if they change the process that allows unfair competition and that doesn't have a 77%. They don't have to take Medicare. They can take only commercial rates. So they cherry pick the good stuff.
Medicare or Medicaid?
Right. Either. Yeah. So Medicare mainly, right?
Okay.
So they don't have to accept. They don't have EMTALA. They don't have, so if you're not taking Medicare patients, then I have a 77, so the 10% of commercial payers, they're going across the street. I lose that income. There's no way for me to raise prices. So I have to then fulfill my fiduciary responsibility and start cutting the services that don't make money. Well, it's places, things like trauma and Children's Hospital that don't make money. It's the right thing to do. So we do this business in order to be able to pay for this business. That's all rural hospitals across the state.
Right.
So how it impacts the local economy is just, again, the city of Pikeville is the economic engine. Again, the industrial park, the university, the banking community, the educational community is all housed here. Imagine if the city of Pikeville were to lose 25, 30, 40% of their income from the largest business in Eastern Kentucky. Kind of what happened to us during the coal boom, or as the coal boom went away and the war on coal took over, is that, and I was the city manager at the time and knew how that impacted our finances also. But luckily, healthcare has risen to the top, and the beauty of that is it's not about, it really isn't, because we talk a lot about economics right now, because that's really where we're at. As a nation, you hear a lot about the shortage, but it really is about access to care and quality of care.
Well, just one final question, and it's kind of dealing with like behavioral health. So we know that at one time Northern Kentucky was called ground zero when it comes to the drug epidemic, but also Eastern Kentucky shared that identity. We do know that there is, you've mentioned, I was thinking more mental health trauma, but we know there's a lot of mental health needs that are going unmet. Where is Pikeville Medical fitting into that, or can it have a role in helping there?
The answer is yes, but just the complexity of this issue is that there's not a lot of mental health professionals that are available out there, and that's another crisis in the state. So one of the things we're doing to try to combat that is that we're working. I've had multiple meetings directly with the governor. I've got a meeting coming up with President Stivers, and what we're trying to do is to put together a residency program that would offer a psychiatric residency here in Pikeville. So there's only one psychiatric program in Kentucky, in Louisville. We'd like to be the second one. The problem, which speaks to the issue, is that all hospitals and professional organizations, like universities, et cetera, to do psychiatry is a very, very expensive venture. You're going to lose money. But the question is it the right thing to do? So looking for possible partnership, subsidy, not saying that we're not willing to partner, because we realize it is such a huge issue. And our partner in this endeavor is also ARC. So Tim Robinson with ARC. Who,
Addiction Recovery Center.
Yep, I'm used to acronyms, my apologies.
That's okay.
So in working with Greg May and Tim Robinson, with what he's doing around the state, there is a component to where they need psychiatric care as part of the drug recovery component. So our offer is let's all kind of partner together, the state, drug recovery, and then it will also allow us to address our concerns, which is the mental health. We face it also as an industry, knowing what we've gone through. Imagine in healthcare,
right.
Our people were still the only ones left that were in masks, and we're still working 12 hours a day, watching people unfortunately perish because of a bad epidemic. So we've had issues internally that we've had to deal with and offer care. So we have Code Lavender. So we have a more, we're a Christian organization. That's how we were founded upon. We still are. We open every meeting with prayer, and it's who we believe and what we believe in. So our ministry plays a huge role in the holistic healing component of what we offer and do. And of course, it's patient choice. But also in ministering and attending to our own staff has become somewhat difficult at times because of what they face and what they deal with. So again, it's like everything else. I think that the COVID has brought forward has really increased the need. The problem is, and I started to say this earlier and I didn't say, but I will because it speaks to it, is that when you look at our educational infrastructure, and I'm a huge proponent for education and what our facilities offer here in the mountains. I mean, they do a wonderful job. However, we're behind times. When you look specifically, multiple meetings with KCTCS and saying, look, I'm the #1 employer in Eastern Kentucky, but do you know how many healthcare programs you have at Big Sandy? 0, not one. But we're still looking at things like Diesel Mechanic and those type of things, and they're great. It's not that it's not a great organization. You've got to be able to pivot. So our educational infrastructure isn't where it needs to be to support rural hospitals specifically, because most of our graduates are coming out of the UKs or out of Galen's, out of Louisville. So and that was part of where Project Heart kind of folded into all this, is to say, okay, let's really put focus and put dollars, because if you make investments where there's a true return, and don't just throw money at me, make it meaningful. Let's put money into scholarships. Let's create legislation that pays a teacher that want to stay, because right now the problem that healthcare faces is that when you have a nursing program and you can go travel or work in a hospital now for 3 times the amount you can work when you're teaching, they're going to make that decision for the family, and I don't blame them. So there has to be a subsidy to be able to fix that, because if not, if you don't pay the teacher, you're going to pay the hospitals. You're going to pay this absorbent cost. So there is a way of making smart investments, and that's what we want to see with the same thing with psychiatric care and the mental health crisis, is that it's not just about creating programs, but it's about creating meaningful programs that will have a long-term last and will have a return on whatever investment that we're making. So we're committed to doing it, but we're going to have help to get there.
Sure. Well, we know that the cost, the physical, the physiology is affected by the mental, right? And so those people who deal with those severe mental illness issues also probably have a higher propensity for all those cardiovascular diseases and every other thing that costs a lot of money to try to fix.
Well, Renee, that's a whole different thing we could get into. I won't dwell on, but that's part of what we face, especially in eastern Kentucky, is the number of comorbidities that people have on top of what we're trying to treat. So you can imagine, again, the way that CMS, the way that we're paid, and that's a problem. So when you look at readmission, so we get actually dinged for readmission. If we let somebody out of the hospital too soon and they come back, then we actually get dinged for that and make less money. So I've got the sickest patients in the nation, but when you look at somebody in California that's healthy, and you look at the payer rate, now again, there's regional way that they pay, so I don't want to give somebody the false impression. But we can, a DRG payment, which is a certain limit of time that a patient can stay that we're paid. Anything past that, we don't get paid for it. Well, when you've got somebody that may have their gallbladder taken out, but they also have COPD, I can't get them out of the hospital in that 3 days. So because of those comorbidities, there's additional stress on specifically our part of the region, because people are simply not healthy, especially in their older age. Now things are changing, health's changing, and that's why the quality argument is so important, is that if we can educate our youth, we can educate and change kind of the eating habits and all the things that, I grew up, soup, beans, and cornbread, and all those things that we eat. But as we change those things, and we are changing, then it will get better. But for the long term, it's either, look, I say all the time, either you can pay me now or you can pay me later. And that's where we're at, is either you can take care of a patient now and help them get through it, or you can pay for them long term. That's going to cost the state and the federal government a whole lot more money. And that's still the problem with mental health.
That's right.
Either we can fix it now, or they're going to if you don't fix it, it's going to get worse. And as delay of care happens, then it's going to cost the state and federal government a lot of money as we go forward.
Right. Well, this has been really enlightening. I mean, I really appreciate. And I was just curious, can you not fix certificate of need in a regional way? I mean, is there not a regional approach? If Northern Kentucky and Cincinnati have this issue, which I see both sides of every issue, so I see that for them. But if it's a disadvantage for another region that's already kind of disadvantaged, can you not create a more parity system?
Absolutely, you can, and it's a good point to make. So the Kentucky Hospital Association, we just had our retreat. We spent 3 days talking about CON. So the KHA has put together, in essence, a plan to present to the legislators on the things that we just aren't willing to let go, because if it does, it impacts access to care, it impacts quality, it impacts rural health care in general in the state. And we've got to be able to have a strong voice to be able to tell that. But to your point, when you look at the, again, more urban metro versus rural markets, it's a different argument. Not that I'm a firm believer that because of investments that are made, or that have already been made in the cycle of what that we were in, you're going to hurt healthcare if you try to do too much at one time. Because even if you go in and CON even in the metro market, in the interim of what all takes place is going to impact care. It's just going to.
Yeah. Well, this has been fantastic. Anything you'd like to share that I didn't ask you real quickly?
No, I've enjoyed this thoroughly. It's obviously this is a business I'm in. I'm very passionate about what I do and who I get to serve. But coming through, and I guess that's where I'll end my comment is realizing as an administrator, coming through. When I first took over the hospital, it was financial turmoil. We got past a lot of that. Then we hit COVID. We got past that. We're in the workforce issue. We got past that. Now we're in the CON. So it's our job is to offer quality of care and access to care for the citizens that we serve. But there's always something that you feel like you're under fire with, when all you're trying to do as a nonprofit entity is to provide a service and allow the quality of life of people and to save lives. And that's what we can't lose focus of. That's what we're here to do. And so, we've got great legislators. I'm not upset with that. I've talked about education, I've talked about healthcare, I've talked about our industry. People want to do the right thing. It's doing what you do, and I appreciate you, Renee, because when you educate people and you let them see the other side of the story, people can make good informed decisions with good facts, and that's what you're bringing forward. So thank you for the opportunity.
Thank you.